Hello, my name is Adriani Javier, and I'm a student at New England Institute of Technology. And I want to delve into the heart of the American healthcare crisis, exposing the detrimental impact of profit-driven motives on the delivery of quality healthcare. This documentary-style commercial aims to raise awareness of a system prioritizing financial gains over genuine care. Through compelling narratives and expert insights, the commercial seeks to ignite nationwide conversation, urging viewers to advocate for a healthcare system that prioritizes the well-being of individuals and communities, ensuring a healthier and more compassionate future for all.
Hi, my name is Brianna McGibbon, and welcome to Tech Talk. I am honored to welcome our guest, Dr. Larry Warner. Thank you so much for visiting us, Dr. Warner.
Thank you for having me.
Alrighty. Dr. Warner, can you tell us a little bit about your public health background and maybe some of the research that you've done?
Sure. So my formal education is, I have a Doctor of Public Health in Health Equity and Social Justice, and have also looked at how individuals navigate health systems, how social determinants of health, or the non-clinical factors that impact our health impact individuals, things like education, jobs, built environment, and really want to understand what from an individual and community level are things that impact our health and create disparities in outcomes, and what at the systems level can be done to improve access to quality care and to the resources that make healthy communities and individuals.
Thank you. How can you provide us with an overview of the current shortage of primary care doctors in the United States?
Sure. It's a very timely conversation to have, since there's been a lot of work, a lot of research and conversations happening both in Rhode Island and across the US with respect to primary care, the primary care workforce, and how we're measuring up with the supply of providers compared to the need or the demand for services. We know that over the past 10 years, the number of physicians or medical students graduating from medical school and entering into primary care fields has stayed pretty level, and unfortunately the need for primary care access has increased over time, and we've also evolved our thinking as a country about what constitutes primary care. Historically, it's only been thought of as a primary care physician, but now we know that physician assistants and nurse practitioners are an important part of the primary care workforce. With respect to what percentage of nurse practitioners are going into primary care, we've actually seen an almost 20% decrease in the percentage of nurse practitioners that are going into primary care. So with the decrease in the workforce going into primary care and the increase in demand, it makes for a challenging situation just from a numbers perspective. And then as we've seen over the past few years with the pandemic and other health needs arising, it's important to have a robust and diverse healthcare workforce, primary care workforce.
Okay. And just touching back on your previous response, what are the primary factors that are contributing to this issue?
There's a mix of things, some of which are financial, and it's no secret that there are some medical specialties that offer higher compensation in comparison to primary care. Not to say that there are any physicians or nurse practitioners that are not well compensated. They do certainly earn decent compensation, but their peers in some higher technical specialties may make more money. And when you think about the cost of medical education, you have 4 years of undergrad, and then if you're going to medical school, 4 years of medical school, and then residency, and you're not making top dollar as a medical resident coming out of medical school. And the trajectory for a nurse practitioner is slightly different, but it's still accruing debt along the way. And so individuals are tasked with making hard financial decisions with respect to their own personal needs when they're choosing what medical specialty to go into, whether it's primary care or another. There are also challenges around the administrative burden, and there's been a lot that's been gained by the move to electronic medical records and other workflows that help to make the capturing and documentation of information easy, as well as to facilitate e-referrals. However, particularly in smaller medical practices where it may only be a physician or nurse practitioner and a receptionist or a medical assistant, there's a lot happening behind the scenes between appointments, before appointments, often late into the night, where providers are catching up on the notes and entries and billing that may have been generated during their day, the normal business hours activities. And we're also seeing that there are challenges hiring for some of the support roles, everything from nurses to medical assistants to receptionists. If there's not adequate support for the practice, then all of that work falls on the provider. And again, thinking about the compensation versus the stress that's generated from the day-to-day work, it makes for a challenging set of circumstances for providers or people who are considering going into primary care. So there's financial, there's workflow, and then we also want to make sure that while we're looking to build a pipeline of providers, that we're also attracting diverse communities, diverse individuals to diversify the workforce. So I think there's a lot of opportunity there as well, as in addition to thinking about the overall number of providers that we need.
Okay, thank you for that answer. That was nice. Our next question will be, how does the shortage of primary care doctors impact patient care and overall healthcare system in the U.S.?
It can be a challenge with respect to getting into, to see a new provider for the first time. I've heard from people who are pretty savvy when it comes to navigating systems and know what they need to ask and have the information, have health insurance, but there's just not enough bandwidth and not enough time slots or availability of appointments to get into an actual provider's office as a new patient. There are many providers who are not taking new patients. They're only carrying the patient panel that they already have. There are some providers that are working towards retirement, and so they're looking to smoothly transition their patient panel to another provider, or until that person, if they're a pediatrician, ages out of their practice, or if they're a geriatrician, until their patients are no longer of their services, whether it's because they're in a nursing home or deceased. So there are a lot of considerations that around the access piece and getting into a practice in real time. We've seen some promising practices, and again, going back to the expansion of who we're considering part of the primary care team, not solely depending on physicians, but also including physician assistants and nurse practitioners. That does open up some opportunities for an increased number of providers, but again, within even the nurse practitioner space, the percentage of nurse practitioners going into primary care has decreased significantly over time. So it makes for a challenging set of circumstances to get into an appointment for a well visit and to become part of a panel, never mind if you're sick and need to see your primary care provider at that point in time.
Thank you. Moving on to our next question, sort of also expanding on that previous answer, can you share any specific examples or experiences you may have had?
I have had a couple of changes of primary care provider over I'd say the past 2 decades or so. One because my provider relocated, and at that time, as I was learning more about healthcare systems transformation, I was looking for someone or a practice that was embodying some of the better practices at that time. So I ended up finding a new medical home, which was great, and stayed with them for probably 6 or 7 years, and then that provider retired. Fortunately, they were part of a multi-provider practice, but I could not get onto another physician's patient panel even in that same practice. So fortunately, there were a number of nurse practitioners that were options, and I'm being treated by a nurse practitioner as my primary care provider. But it was nearly impossible for me to get onto a physician's patient panel. Now, is that a bad thing? Not necessarily. I think that there's a team-based approach, and so if there are cases or needs that I have or other patients have that the nurse practitioner feels like she needs to consult with a physician on, then there's that space for consultation there, and also there's always an opportunity to consult or refer to another provider as necessary. But for people who have grown up assuming that your primary care provider has to be a physician, there are some realizations now that that's not necessarily going to be the case just from a numbers perspective. It just is almost impossible for folks to access a physician if they're not already on a physician's patient panel.
Great, thank you, Dr. Warner. Moving on to our next question. What role do medical schools play in the situation?
Medical schools have a unique opportunity to address the situation through a few different ways. One is obviously promoting the opportunities and the need for primary care providers, and thinking about promoting it from an interdisciplinary perspective, that primary care providers are part of a team, whether it's within the practice with other providers or with support roles within the practice, or even just in the ecosystem of the healthcare space. They're not on an island by themselves. So there's somewhat a marketing consideration as far as schools talking about primary care as an opportunity. There's also an opportunity to think about how medical education is being delivered, and from the classroom portion to the internships and residency linkages that they have with the community. Think about how do you structure the educational experience for students, for even pre-med students or young people in high school. How do you promote the field of medicine? How do you promote primary care even before people are applying to medical schools or applying to colleges, so that they know it's an opportunity? And also thinking about, what does primary care look like today compared to 20 years ago, 30 years ago? And is our education model preparing providers for the current populations and current communities that they're serving, and with the skills, the tool set, the knowledge, the emotional intelligence to deal with a more diverse, a more complex, an older population now compared to years ago? So there are a number of things from a promotion perspective, from an education perspective, from thinking way further ahead in the pipeline of potential students' perspective. Those are opportunities that medical schools can be thinking about, how they help to address the need for increased primary care providers.
Right. Perfect. Thank you. And then, are there enough graduates that are choosing primary care? And if not, why may that be the case?
They're not, and the data tells us that we've seen a pretty level percentage of medical school graduates going into primary care fields, and a decrease of nurse practitioners, a decrease in the percentage of nurse practitioners. Some of it is financial, some of it is primary care may not have been on somebody's radar because maybe they knew somebody who was a surgeon, who was a cardiac surgeon, or they hear these very inspirational stories that are coming out of other fields, but not so much coming out of primary care. So I think that there's a story to be told about the importance and the impact of primary care across the lifespan. There are a number of providers who start working with their patients when they're older teens, and then they stay with them as they go into adulthood. And if they're having a family, then they sometimes become the family practitioner. So there are a lot of impactful and heartwarming stories of the impact that primary care providers have, but that's not always what makes it into the limelight. It's often cutting-edge technologies, cutting-edge interventions coming out of medical specialties, which are important as well, but that don't necessarily have the same wow factor when you're trying to attract future providers. Then again, going back to the financial considerations, medical school is expensive, there's no question about that. So are we creating the right incentives for students to select primary care as a specialty, as a track, given that they may be making a little bit of a financial sacrifice compared to going into any of the surgical specialties or anything else? So there are some practices and policies being recommended around loan repayment and scholarships to help reduce the financial burden of going into primary care and to make it more attractive, or to at least remove that barrier from going into primary care.
Thank you so much for your insight, Dr. Warner.
Thank you.
We're going to be moving on quickly to a commercial break. Thank you so much.
Hello there, my name is Joshua Leota, a student here at New England Institute of Technology, and I would love to discuss what it's going to take for us to change the way we effectively provide healthcare in our country. To drive this change, we will be sent on a quest to find 50,000 to 100,000 supporters who will champion our primary care revolution. We politely request that you join our organized Zoom meetings and interact within your community in developing primary care solutions, so that your personal engagements become the alchemy behind groundbreaking primary care solutions. With your help, we can aim to establish infrastructures in 25 communities within 3 to 5 years, with a goal of $100K in the first year and an estimated cost of $3 to $5 million by the third year for scaling up trained physicians nationwide. Donations are crucial for our organizing efforts, so that means your involvement and participation will create a very meaningful impact towards the future of healthcare.
Thanks for joining us once again. Now, in what ways are underserved communities particularly affected by the lack of primary care physicians?
I would say that there are a few different ways that communities are impacted. One is just from the pure availability of providers, just at a blanket level. There may not be a practice near them physically. In urban communities, there's a better chance that just geographically one is accessible either within the community or by public transportation if that's a need. Where it gets more complicated is in rural communities where both availability and distance may be factors as well. And in Rhode Island, for example, the Department of Health office that oversees primary care also oversees rural health. So it's Office of Primary Care and Rural Health, thinking about primary care from just a service delivery perspective, but also from a geographic availability. So there's that. And then there's also the question of what goes through someone's mind when they're seeking care and there aren't providers available that look like them or that can relate to their experience or that have come from their communities. And it's been revealed through different studies that people are more likely to either feel comfortable or to trust the advice that's coming from their primary care provider if it's someone who looks like them or demographically or can relate to their lived experience, which is important when you're trying to coach someone through health promotion activities or healthy lifestyle decisions, or someone who can understand the barriers to what in some communities are healthy choices by default. Many communities don't have those same resources made available to them, whether they're access to healthy fruits and vegetables or walkable streets or green parks or anything like that. So there may be just a realization that the experience of many of your patients might not be like that of the textbook. And that's an important piece of the puzzle as well. So having a diverse workforce, having an accessible workforce are all crucial parts of having a healthcare delivery system, a primary care system that's accessible, that's reliable, that is trusted by the communities that it's serving.
Thank you. And expanding on that, how does this exacerbate health disparities?
It can exacerbate health disparities from a trust perspective. It was interesting. I'm not a healthcare provider in that sense, but from my public health background, often am sharing some of the same information that may be coming from clinical providers. And during the pandemic, there were people who were hesitant to participate in vaccination because of the timing of when vaccines became available, the limited history, and also they didn't see faces that looked like they reflected their communities conveying the information. So there were a number of efforts across the country and in Rhode Island to have people of color be part of the public health messaging workforce or messaging efforts. I had friends who reached out to me over social media when they saw me on one of the Department of Health quick snippet videos and had some questions about me and whether I trusted the vaccine. And it was telling to me that someone who saw me or other people who looked like them thought that I could be and others could be a trusted source of information. So translating that back into primary care, a lot of times people are hesitant to trust voices that don't understand their setting, their experience, and that is a crucial part of why it's important to have a diverse workforce, an accessible workforce, a workforce that reflects and understands the experience of the communities that they're serving. And without that, you may be trying to address diabetes disparities or heart disease disparities. If you don't understand the root cause for those disparities, you'll only be treating the symptoms as opposed to the underlying root causes.
Thank you for that insightful answer, Dr. Warren. Moving on, what are the financial implications for primary care doctors compared to specialists?
There's a little bit of a trade-off. Most medical specialties make more than a primary care provider. And so again, in thinking about the strategies that will help to remove the barrier of entry into primary care or to make it more appealing, there have been loan repayment programs in the state of Rhode Island for primary care providers, particularly going into urban or underserved areas, to help reduce their debt burden and to increase their likelihood to practice in the setting. There have also been longstanding programs to have primary care providers participate in the Indian Health Service Program and other similar programs that are addressing the needs of underserved or historically under-resourced communities. So there is a consideration of the barriers the barriers and facilitators to entry into the primary care workforce. And so removing those barriers hopefully will increase the enticement and the likelihood of providers going into primary care specialties. The other thing I would offer is that there has been a lot of work done to think about how we change the healthcare payment system and payment models, both locally in Rhode Island and across the country. We have historically operated from what's called a fee-for-service model, where it's more transactional. If I go to see your medical practice and I'm in the setting I have a 15-minute appointment, there's a set rate for that 15-minute appointment, and you bill me for that 15-minute appointment, or you bill my insurance if I have insurance, and so it's very transactional. Now we're thinking about what's called value-based payments in healthcare. And the goal is to be less transactional on a fee for a specific service, but thinking about all of the services and resources that are necessary to manage my health. How do we structure the payments in a way that adequately compensates the provider or the provider team and have some incentives built into it so that if the only reimbursement model was every time I come to your office, you get to charge me X number of dollars, there's no incentive for you to prevent me from coming to your office. So thinking about how do we promote value within the healthcare delivery system, not punishing people, but also making sure that you're getting the most resources and reimbursement for your time with me as your patient, and then encouraging collaboration and coordination across providers so that we can keep the costs down, keep the quality and access and outcomes high.
Amazing, thank you so much. Following up, or going on to our next question is, how does this disparity affect the choice of medical students and young doctors when they're choosing their field?
It can affect the choices being made by aspiring students or earlier career professionals if they don't see someone who looks like them in the roles that they're considering. And it's especially true in medicine, but it's not unique to medicine. If you can't see it, you can't believe it, or you might not believe it if you don't see someone who looks like you in those settings. So it's important to have both outreach opportunities, internship opportunities, exposure opportunities, to be out in the community and relevant to the community, and then to provide engagement opportunities for providers who are coming from diverse backgrounds so that young people or medical students or college students who are in the pipeline or could be on that path to success knows that there's someone who may have come from their background or a similar background and are successful in what they're doing, and then they can envision themselves in that space as well. So it's important to see yourself in roles that you aspire for, and that can be part of what helps to set up our primary care workforce for success, both attracting interest from diverse communities and then also engaging with people from those communities, and so that aspiring medical students and healthcare professionals can see themselves in those roles.
Okay, thank you so much for that answer. Moving on, this is a bit of a lengthier question. Telehealth has seen a significant rise, especially during the COVID-19 pandemic. Can it be a sustainable solution to mitigate the shortage of primary care providers, or does it present new challenges?
Both. I would say that it is a good tool to have in the toolbox. And we have seen that, particularly with behavioral health and primary care, that telemedicine was an important resource and tool to have during the pandemic. And we also saw some significant outside-of-the-box thoughts on reimbursement for telemedicine. It had historically been reimbursed at different rates than in-person appointments, but there was a lot of advocacy happening from the provider community that says, you're providing the same service to me, if it's over a phone, over Zoom, over whatever platform, why should it be any different than if I'm in your office if you're doing the exact same service? So that spurred some interesting conversation locally and across the country. And I believe in Rhode Island, and within the past 2 years, there was a parity bill passed where telemedicine appointments can be billed at the same rates as in-person appointments, at least for behavioral health, if not for all appointments. So that's one important approach, both making sure that it's available as a tool, it's being equitably reimbursed. However, it's not a solution for people who don't have access to the technologies that would facilitate that. And as we saw during the pandemic, both with respect to education and people having to transition to remote learning or jobs that allow for remote jobs, or people who are relying on access to medical care historically in person, being able to do that over a remote platform, that was an important tool to have in place to facilitate that. However, you can only use it if you have access to technology or if you can afford internet access. One of the relatively recent initiatives that had been spun up by the US government was the Affordable Connectivity Program, which helped to provide subsidies for internet access for low to moderate income households. That was a great effort to make sure we're removing costs as a barrier to internet access. Unfortunately, the program was recently sunset due to financial constraints at the federal level, but it presented a lot of opportunity to remove a barrier to access to telehealth, telemedicine, telebehavioral health. And so it remains to be seen what was the impact of having telemedicine as a tool more readily available during the pandemic and initially the year or so after the peak of the pandemic. But now with the sunset of the Affordable Connectivity Program, will we see a difference in how and who is using internet access for telemedicine purposes, and are we seeing worsening in access as a result?
Okay, thank you so much for that answer. We'll be moving on to our next question, which is how can we encourage more medical students to pursue careers in primary care?
We need primary care providers, we need specialists, we need all of the above. However, we're not doing society a service by not adequately staffing our primary care workforce or attracting people into the primary care workforce to tend to the day-to-day needs, the health promotional needs, the annual checkup needs, the sports appointments, the well visits, the prenatal visits, all of those things that are intended to promote health and keep people from getting sick or injured. That's where we need to focus our investment and a priority on. From the government side, investing in programs, thinking about curriculum, thinking about reducing the debt burden and lowering tuition. From the education side, how are we making sure that the medical education, whether it's for a physician assistant, or nurse practitioner, that is keeping pace with the times and leveraging appropriate partnerships. And then what are we doing to attract the future workforce? Are we using data to inform where we should be recruiting? What are we going to need for a primary care workforce next year, 5 years from now, 10 years from now, and then starting to work on that now instead of waiting until we look back and say, hey, we're still 20% down on our nurse practitioner workforce. So there's a lot of forward thinking that needs to happen. It needs to be data informed, it needs to be community relevant, and we're seeing a lot of promise and preparation happening in those spaces in Rhode Island and across the US as well. So I'm hoping that we'll see all of those efforts come to fruition and put us in a better place in the coming years.
Okay, and in regards to that, what incentives or support mechanisms might be the most effective?
A combination of scholarships and loan repayment, mentorship, shadowing opportunities, just thinking about at the different stages of engagement. Obviously someone who is in medical school or applying to medical school and thinking about what the next steps would be for them once they start to see the tuition bills and think about, all right, this is going to be over 8 years. How am I going to pay this back once I graduate from medical school? If they have assurances that going into primary care is not going to set them back at a disadvantage compared to their peers who may be going into other specialties, then that is a more promising approach and equation for attracting them into primary care. And then from a mentorship perspective, it's always helpful not only to see someone who is reflective of your background or your experience, who is further along in their journey, but to have them as a coach, to ask questions, just to know that they're accessible, that can do wonders for helping people to persist through their journey as well. I don't have the data offhand as to what the persistence rates or dropout rates are for medical education, but if the data informs us that we need to be thinking about supports beyond financial to help support the success of medical students, especially as we think about the need for diverse students from diverse communities and diverse backgrounds, we want to make sure that we're not just supporting them financially, but supporting them socially, emotionally, academically, and then again, looking as far ahead into the pipeline as possible, not waiting until young people or early career students or professionals are at a key decision point. At that point, it may be too late to incentivize them or to present primary care as an option if they haven't been thinking about that before. So if we can start well early into, or much earlier into the educational journey than we have been historically, it can be truly impactful to have exposure opportunities for middle schoolers even to know that, oh yes, okay, yes, I can be a doctor, or I can be a physician, but primary care, that's the person who mom takes me or dad takes me to every year to get my physical, to get my checkup, or who takes me to be seen if I have a fever or anything like that. There may not be that distinction in that child's mind, but if they become aware, oh, this is someone who plays a special role in my family's life, that could be something that they can more tangibly think about as they grow up.
Okay. Thank you so much for taking the time to answer those questions. We are quickly going to move over to an informational break. Thank you so much. Hello, my name is Brianna McGibbon from New England Institute of Technology. Let's talk about primary care for all Americans. Now that we know why it's important and how to get this done, what's left to wait for? Join us in the battle for the healthcare system of all us Americans truly deserve. Together, we can make a difference and make healthcare more accessible for Americans one day at a time. Join today at primarycareforallamericans.org and let's change America for the better. Alrighty, thank you so much. And looking towards the future, what do you think the landscape of primary care in the United States will look like?
I'm going to be optimistic, and I'm going to look into a crystal ball that shows me a robust, interdisciplinary, and diverse primary care workforce that's accessible in every setting, from primary care in urban communities to suburban communities to rural communities, that takes an interdisciplinary approach, works closely across physicians, physician assistants, nurse practitioners, and that also engages with other specialties or other professions as well, whether they are pharmacists or paramedics and EMTs. There are a lot of new models of extending the primary care practice into the community that are being employed. So my crystal ball tells me that there are going to be there'll be some progress made in the next few years. That combined with the continued practice of resources like loan repayment and scholarships and tuition assistance that reduce the financial barrier for potential primary care practitioners. I think that those will start to, or they'll be continued to be invested in, and they'll start to have a return on investment. I also think that there's going to be continued, and the signals are all there, that we'll see continued progress in payment reform and how practices are reimbursed and how payments are structured, so that we're thinking about how do we deliver the best care at the right place, right point, right time, with the right partners at the lowest cost, but with the best outcomes. And incentivizing all of the best ingredients and best practices in primary care and healthcare delivery, and recognizing that there are things outside of the clinical setting that impact people's health. And I think that that's one thing that we may not be mindful of as we're asking healthcare providers and healthcare systems to not just care for medical needs, but also to screen for social determinants of health or health-related social needs like food insecurity, housing instability, unemployment, trauma, depression, things that contribute to one's health status. I know that there's a lot of work being done to capture that data now, and at the federal level, tracking of social determinants of health or health-related social needs in billing codes will help us to better capture what it is that our patients are experiencing outside of the clinical setting, but it has impacts for their health outcomes. So I think we'll see progress on that front as well, and then factoring that into what does a billing structure need to look like to adequately support healthcare delivery for our patients. and to address the needs outside of the clinical setting that have impacts for their health. So my crystal ball looks pretty clear. I think I'm optimistic.
Okay. And now, Dr. Morin, do you think that we are moving towards a more sustainable model, or are there more significant challenges that are yet to come?
I think we will always have some challenges, and no model is perfect or without its challenges. I think there's a lot of interest in looking at what healthcare systems outside of the U.S. are doing well. There's work that's being done, I believe, by the Commonwealth Fund that looks at national healthcare systems and both from a training perspective as well as a delivery and payment perspective. What are they doing that are practices that we should consider here in the U.S.? We have a lot of national pride and think that the U.S. way is the best way, but there are other ways that work well that we can look at some of the best practices and see if they would work here in the U.S. And I think that those are considerations that will help determine to what extent we're successful in transforming healthcare delivery, primary care access, payment reform, and so on.
Okay. Well, thank you so much for your time today, Dr. Warner. We appreciated all of your input today. Your answers were very insightful, very informational, and I enjoyed being able to host you today.
Thank you. It's my pleasure. Thank you for having me.